Hello, everybody, and welcome to another Pilates Hour. We're so excited to have everybody with us today and to be back. Last week, I was traveling, and again this week traveling. I've been in New York and San Diego, and finally back home last night after midnight in North Carolina. And today, I'm super excited to have with me Cecilia Pulido. And Cecilia is a well-known Pilates teacher. She is a Polestar grad. She is a graduate of Lolita's Legacy program, and she has been working in specifically with the Parkinson's disease and patients with Parkinson's for a number of years. And that's our topic today. We're going to be talking about Pilates for Parkinson's. No pun intended. That's the name of your business, right?
Right, right. And it's Pilates 4 instead of FOR. So, yeah, just that distinction. We actually have 4 pillars that we work from.
You know, that my wife asked me that today. She says, "So, do you think the four stands for something particular, or is she just being cute with the word FOR?" And I said, "No, I think she probably has some
Yeah,
principles or pillars or something like that." So,
yeah.
anyway, let's get started. Cecilia, welcome. Good to have you here.
Thank you. Thank you so much for inviting me. I'm so happy to be able to share what I'm doing.
Now, your background goes in movement goes back way before Pilates. Maybe give us a little shout out of your experience. I know it's in martial arts and in the mindful aspect of martial arts as well. Tell us a little bit about your background in movement. Where did it begin? How did your interest in movement happen? What led you to Pilates? Kind of give us that history.
Yeah, so I kind of backdoored my way into Pilates from the fitness industry. So I've always been very active in fitness and used to just be a regular gym person and aerobics person and fitness person. And then I got into Chinese style martial arts about 25 years ago. And I studied Pakwa, also called Bagua, which is the 8 changes. Pa is 8 and Kwa is changes. And it is a system of Chinese arts and sciences, which isn't just physical. It involves a lot of Chinese philosophy, and you study everything from martial arts to Tai Chi to Chinese yoga, nutrition in the Chinese line of health, energy, meridians, reflexology. It's just a very all-encompassing study. And so I started there. And then from there, I started, when I lived in Puerto Rico, I started doing a lot more fitness. So everything from, I was a TRX educator for 8 years. I was a kettlebell master trainer for quite some time, a yoga teacher. So, it just all, and then I fell into Pilates and eventually met Lolita San Miguel. And my journey with Pilates started there, and it's been a really fabulous journey since then. And I will say that now I really appreciate and understand everything I went through to get to this point because I have truly pulled it all together in this method that I've created.
Yeah, it's amazing how the many experiences we have in life, and that's why I always think there's a richness in those that have, indulged in multiple pillars of studying movement or being an athlete or dancing and martial arts and having multiple components or exposures to how movement plays a role in life. And one of the things that we'll be talking about in the pathokinesiology course, the first series, is really looking at what is normal. And when I say normal, no, there's no such thing as normal. It's sort of like we could say normal for somebody that does martial arts in their 20s. We could say normal for women that are peri or postmenopause. We could say normal for elite dancers. We could say normal for long distance runners. And each of them are going to have different parameters of normal. So the more exposure we have to different exposures of movement, the greater our data banks are in being able to call upon them and to integrate the different methods, the different lessons we learned in those movements. And that's no exception for you as well with your nice diverse background. How did you get to Puerto Rico?
That's a really long story, but long story short, I moved there in, oh my goodness, 26 years ago with my then toddler. I had a job there. I used to work in the natural products industry, and I took a job in the rainforest for a very big, at the time, a big living foods farm and resort. And I went there to restructure them and to get the living foods products into the market and such. And so this was a really amazing experience because it really informed me on how just that connection to living foods and vitality works. And so that was a fabulous experience. I went there for a 3-month contract, and then when I finished, I was like, I love Puerto Rico. I want to stay here. And so at that time, I just got an apartment in
Were-
Dorado,
Okay, I
the
was going to ask,
beach
were you
area.
living in the UK? Were you
I
actually,
was, I
yeah,
was at the very top of the mountain, where there's only rain and forest,
yeah,
literally.
yeah, yeah.
And yeah, and
I
then
have I have pictures of us there where the leaves are bigger than me on the
yep,
plants, and I'm, hiding. You see me, then you don't see me. It was just, I mean, it's always wet. It's always rainy up there.
and it's always spectacular,
Yeah, yeah.
it's
Love the
beautiful.
waterfalls.
Yeah. And that just kind of took a life of its own. And the next thing I know, it's 14 years later. And, we're in Guaynabo by this time, and a major city suburb from San Juan. Mhm.
Guaynabo, llevando guayaberes, comiendo guanabana.
Right.
That was my joke in Guaynabo.
Puerto Rican tongue twisters.
Yes,
Yeah.
yes. Well, very good. Let's get started a little bit, and I guess going from your original training when Polestar was doing the training at Lolitas at the dance um, ballet concierto de Puerto Rico. That's where the
Hmm.
training was taking
Right.
place. Yeah, is that where you went for the training?
Yes, yes. And actually, what happened was as you know, as I mentioned, I studied Paqua for many, many years. And so I used to always have a studio. And in my studio, I taught a lot of different classes. And I had already by this time went through the whole mat Pilates craze. I got triggered into it with Mari Windsor back in the day and just loved it, and just I don't know, never made a connection that it was Pilates. I just always incorporated all those mat movements in so much that I was doing. Finally, one day a client came in, she goes, gosh, she goes, it's so great how you incorporate mat Pilates into everything you do. And I said, what's Pilates? And she says, well, she started telling me, and then she says, well, Lolita San Miguel is here. And I didn't know who that was. And so it turned out that this client, bless her heart, she got me on the path. She gifted me a private session with Lolita. So I went, I had my session with Lolita, and it was great. And then it was that started me into the training program. Lolita referred me in, I signed up, Polestar delivered it, and then,
And you had
it was just
Rosa.
from
You
there.
said you had Rosa
Rosa
Passer.
Passerin,
Mhm.
yeah, she was fabulous. Yeah,
She's wonderful.
very articulate and
Yeah.
kind. Yeah, yeah.
Well, that's some good roots. And then you went on to be part of Lolita's legacy as
I
well. I
did.
saw a picture of you in the group with Claire Sparrow and a couple others
Yeah.
that I know that are Polestar and Lolita. So very
Yes. I got a note from Claire this morning, so that was really lovely. So I started commuting. I was still living in Puerto Rico, but I made the decision to get serious about Pilates. So I started commuting back and forth from Puerto Rico to Florida, where Lolita was based, and going through her whole legacy program, which was, a bit of an arduous process, but fully worth it in the end. And then was invited to come into the Master Mentor program, and continued on with her, and then became an educator, and went
Now, where do you
went
live
that
now?
route.
Where do you live now?
Now I live in Eugene, Oregon,
Oh,
in the
that's what you
Pacific
said, Eugene,
Northwest.
Oregon. Well, that's as
Hmm.
far as you can go from Puerto Rico in the United States.
Yeah,
I
yeah,
guess you
it's
could have gone
lovely.
to Seattle, but
Hmm.
wow, Oregon. Well, you're a Northern California girl anyway, so you grew up in sort of Central Valley, North Valley of California.
Yeah, kind of Central California, an hour from Monterey Carmel inland. Yeah,
I was born in Salinas.
that's where I went to school. A private girls' school, Notre Dame. I'm
Mm.
sure you know it.
What year did
Notre
you graduate from high school?
I don't even remember, honestly. I'd have to do the math on that, but it was
Okay.
probably 84, I guess. No, no. Yeah, I think
All right.
84-ish.
I know everybody wants to hear this, but I was 81. So we are very close. We were contemporaries in that area. That's very funny.
Okay.
Very cool. Well, let's jump into Parkinson's disease. Let's
Yes,
jump into
please.
this and let's take a look at. Well, I was going to guess that you graduated like in 92 or 93 or something. So you're doing good. You're doing good. If you actually graduated 10 years before that, I guess some people could figure out the math for us, but that's the
Mhm.
problem. All right. So let's talk a little bit about your exposure and passion for working with persons with Parkinson's disease. How did that come about?
So, as I mentioned, I used to study and teach Chinese style martial arts for many, many years. And one time when I was living in Hollister, I had sharing a studio there. A woman came in and she had a teenage boy with her. And she says, I need to find someone to train my son. He needs exercise, but he's very bored and he's not paying attention to, trainers or gym people. She goes, I need something he's interested in. And I honestly didn't even know what Parkinson's was. I had no knowledge of that. And I said, sure, I'll take him in. So I started doing privates with him. Now, this young man was diagnosed with Parkinson's when he was 8 years old, but his symptoms actually started at 5. And so at the time, he's now 41. He just had his birthday. But at the time, it was so unheard of that someone so young could have Parkinson's disease that it took literally 3 years to diagnose him. And he had to go through so many different trials and tribulations to get that diagnosis until finally the doctor was like, just give him dopamine. And within half an hour, this is the story his mother shares with me, he was outside playing like a normal kid again. And so we started working together when he was 15 years old, and I started taking him through what I knew, which was a lot of the drills and the different things with the Chinese style martial arts, and then incorporating some of the mat stuff that I knew, not being conscious of the fact that it was Pilates, just kind of like fusing it all together to get what I wanted out of his body, the type of movement I was looking for. And he responded so positively and so much so that his doctor asked the mother when they went in for a visit, what is he doing? Because he moves different, he looks different, his postures, everything's different. So his mother told him, and the doctor was so surprised, he actually wrote a prescription for more so that his mother could get some support from insurance. And so she increased his sessions, and that's how this all started. Yeah.
Very interesting. I mean, it's amazing. I don't know that I've ever seen anybody young with a Parkinson-like disease. Did they,
Unfortunately, it's getting younger and younger. Young onset is growing very quickly.
and obviously it's the dopamine deficiency or receptive of the dopamine that is deficient in the nervous system, usually from the substantia nigra. Did they have a specific diagnosis for him of why he was having the dopamine?
Parkinson's at that
Yeah.
age?
Hmm.
No, I don't know the details on what his exact on the factors that contributed to his diagnosis, but I do know that risk factors such as traumatic brain injury, a genetic disposition, exposure to chemicals, or things of that nature, even just being Caucasian male over the age of 50 increases your odds for
The
developing
incidence, the
Parkinson's.
incidence
The
is
incidence,
higher.
yes,
Yeah.
the incidence, right.
Um, yeah, that's very interesting. Like I've worked with a lot of patients with Parkinson's disease and sort of thinking of the, you and I were talking about a little before we started, the idea of movement as medicine and how there are very unique things in the Pilates environment that lend themselves to successful interventions for Parkinson's. I'd love to have you talk a little bit about how you've come across that. I mean, you've developed your whole work based on that. What are some
Absolutely.
things that you identify Again, I know there's bias in there because of like if you had gone through maybe a different Pilates training or something like that, there might be some different interpretations. But I know what your background is between Polestar and Lolita. Um,
And there are other trainings too, which I'll mention later. But yeah, let me jump in and just be really clear on why and how exercise works for especially people, for everyone, right? It's great for everyone, but for people in Parkinson's in specifically, it's really movement is not optional. It's a primary intervention. And exercise in particular is what would be considered the only non-pharmacological approach that can help attenuate disease progression. So even the pharmacological medicines, the treatments, the levodopa, carbidopa treatments, they are not attenuating progression. They're only helping with the motor symptoms.
yeah,
So in the case of exercise, you have skilled exercise and then you have cardiovascular exercise, and both do very different things. My method, Pilates for Parkinson's, really hones in on the skilled exercise portion of it. And this is very important because I'm sure you're familiar, and a lot of the viewers today are familiar with brain neuroplasticity. So with the skilled exercise, you're looking at specific complex cue-rich learning-based movements, which help spur more brain neuroplasticity, right? And with the cardio aspect, you're looking at ramping up or increasing BDNF, which is your brain-derived neurotrophic factor. So those two things together really help not only support preservation of the neurotransmitters and the neuromodulators that you need to function, but they also help you move better through different areas like your fascia, your cognitive ability is a little bit more clear. So I want to just say one last thing, which is I'm so strong about this because Pilates teachers are such an amazing resource for the Parkinson's community. You have very skilled Pilates teachers on this side, and Pilates teachers not only have like a basic command of anatomy, some physiology, but a lot of them have specializations: pelvic floors, spinal asymmetry, hypermobility, etc., right?
mhm,
And so you've got a very talented resource right here. And then on the other side, you have people who have Parkinson's disease who need very specific movement. But then there's this huge gap in the middle, which is the pathophysiology piece, where if you don't know what you're dealing with, you really can't just throw exercises at it.
yeah, yeah,
And so Pilates for Parkinson's provides that bridge.
yeah.
And
We've seen that so much, and this is obviously a passion of mine and has been for almost 40 years, is to bring that level of like if you understand what's causing the movement impairment, then you are going to understand the indications, not just the contraindications, but the
absolutely.
indications that are going to help the most. And I remember working with somebody where, we used a laser light to be able to facilitate movement out of a freeze state, right? So the patient was stage 4 in the Jan scale and pretty advanced and was in a frozen state. But when we gave him a specific task, like step on the laser light, all of a sudden he could move and take the step. Where if you told him to walk or to, put one foot in front of the other, there was no movement happening. But when we
Absolutely.
used something that was an external cue, and that was when I started realizing, probably like 20 years ago, that if we're playing games and creating very, like you said, very specific skill sets, it triggers a very different neurological response than relying on things that they had as subconscious automated movement. So you think of things like walking or getting out of a chair, those were things that were very much habitual in the nervous system. And the lack of dopamine sort of blocks that. So that's where they get stuck. But when you
So
create
deep.
skill set, it's very interesting that a different the execution of learning something new. That's why things like art and music and Pilates and rock steady boxing. I mean, there's a lot of things that are actually incredibly beneficial to be able to keep the dopamine centers working. And a lot of that has to do, and I saw something in your, I think it was on your website, Cecilia, but just talking about when you really understand what dopamine does, it's much more than, just freeing up movement. It has so many functions in our body.
Yeah.
And with serotonin, that balance, and looking at using other modalities to stimulate a dopamine response actually is something we can do if we understand that's what we're doing with some of the tasks that we're training.
Indeed. That is all true. The only thing I'd like to add to that, or to augment where you're going with that, is that with the Pilates for Parkinson's method, it's not just the external cueing or entrainment to get them to do a skill that they already know, but we have to consider different factors. Like, for example, as you were saying, in external cueing, music, like neurologic music therapy. Even though we are not neurologic music therapists, we could use like RAS, rhythmic auditory stimulation, which music overrides the brain, right? It activates more of the brain. So you're not targeting specific pathways, you're just lighting up the whole brain, which is why you get better movement when you're using music. And then going back to rhythmic auditory stimulation, it's like using metronomes or beats, because then you're bypassing that timing piece in the brain and you're providing that external timing, which the brain can recalibrate to improve walking or movement in general, right? So that would be one piece. But then the other piece is what you were mentioning earlier, is that it depends. It really, really depends on what stage the person is in, because my method is very stage specific, right? And I look
Where do
at
you
my
see, where do you have something for every one of the stages, or do you?
absolutely,
Yeah.
and you have to, and I'll give you a very clear, simple reason, which is, if you get a client who's in stage 1, they were recently diagnosed, and they come straight to you and they're like, let me just get this started, you have a completely different protocol than if you begin with a client who's already in stage 3 and who is just kind of coming into movement. So the programming that you're going to design is going to be very different, because as Parkinson's progresses, motor learning capability diminishes. So in a stage 3 client or a mid stage, and again, it's different for every single person, but in a mid stage client, you can't really rely on new motor learning. So you have to start turning towards implicit learning. So things they already know, number one. So for example, if I know the
Marching.
history of
Yeah.
my client was a tennis player, then I know that they have inherent in their body, in their cellular memory, in their fascia, the ability to rotate, right? So I have to draw upon that to pull that back out for them in mid stage. Another thing with mid stage, because motor learning diminishes, is that I would also look at things like the 7 primal movements, the neurodevelopmental sequence from Gray Cook. Those are things that are inherent. You couldn't have grown into an adult without doing the 7 primal movements or Gray Cook's neurodevelopmental sequence. So your thought process, your approach to the programming has to change. And that's why Pilates for Parkinson's is so successful, because it really takes into account the individual, the stage, the background. You just had Dr. Ginger Garner on here a week ago or so, and
Couple
she
weeks ago.
talked about, yeah, she talked about her piece where she listens to the client. And that is an absolute must in our method, because that's where you're drawing information to inform the programming. So
Absolutely.
yeah, in Dr. Garner's instance, she was talking about listening so you can create the appropriate programming. But with Pilates for Parkinson's, you're listening because that information is going to inform the programming. It's kind of like a reverse bridge, of what
Well,
you're going to
it's
select.
actually, and Carol Davis would talk about this as well. It is the right way to go in interviewing clients and patients, is creating the listening component to it, because in their story, is where you're going to gather the information. So you can sort of think backwards on this, is that a patient knows what they need, they just don't know how to say it.
Right.
And so
I'm
when we
100% with
listen
that.
to that, then it's very clear how that's going to transpire. Like, it gives us ideas of connections and ways to communicate with them. I also noticed that you use a little bit of neurolinguistics. We use a lot of neurolinguistics in Polestar.
Absolutely. Yeah. And it's not
Expand
just
on that a little bit.
neurolinguistics. And that goes back to what you were saying, like as we're learning and going through different phases of learning in our lifetime, I went through a whole phase where I went up to Canada and studied neurolinguistic programming and thought it was amazing, amazing. Never did I realize then that in my future, 10 years later, it would become an integral piece in how I work with the clients. And you have to have this piece because the reason why the method is successful, my method is successful, is because you have got to get buy-in from your client. And the buy-in comes when they trust you. So you have to arrange things so that you can engender the trust and the confidence of your client, and they understand that you are on their side. You know, it's a very difficult and arduous journey.
Compare it to traditional medicine, Cecilia. To compare it to the 5-minute authoritative visit with a physician that we're all used to now.
Right.
And,
Where they just
and
go through a format
no,
checkbox.
they look at your film, your studies, your blood tests, whatever, and they're telling you what they're seeing versus really investigating, what the patient is
Absolutely.
feeling and why they're there. And I teach this at the university for the physical therapy students. Like, how do you use some basic neurolinguistic skills? For example, all of our Polestar faculty have been trained in basic NLP, basically to navigate any kind of conflict that might come up or frustrations with students, and how to
Mhm.
de-escalate and how to create the trust that
That's
you're
very
talking about.
important. Yeah.
It's super important, and it's much more important than somebody teaching repertoire. It's being
Yeah.
able to navigate
And
communication.
to make the
Communication.
connection
Yeah,
with
that
your
is
client.
communication.
But you can take that even further. So one of the things I use a lot is anchoring, you know.
Mhm.
If I want the client to start to change a pattern, you know, I will use specific cues in my voice, the tone of my voice, maybe like something higher, or I'll give you a perfect example. One thing I teach, because I teach regular Pilates too, and when I teach teachers how to teach the 100, I specifically give them the example to go ahead and cue the 100 all the way through. Do not clap your way through the 100, right? When you get to the last set of 10, start the clap then. And you're going to see everybody perk up and pump pump the best they can. And everyone is blown away when they see that. And that's because of two reasons. Number one, it's an NLP technique. But number two, it's a dopamine signal. So dopamine responds to sound, to clicks, to claps, to loud noises. So it's like everybody alerts up and will start that stronger pumping.
Mm.
So these are little things that are added into the Pilates for Parkinson's method that really, extend the programming and make it so much more full.
And that makes so much sense. I mean, I've done that forever, as far as that last 10 beats of the 100 is to come in and create some kind of rhythm. It's got 10 more beats, and 8 and 7 and 6 and 5 and 4.
Mm,
It's like, and you see the light come on. You see
yeah.
the vibrant energy starting to manifest versus them falling and collapsing. It goes the other direction.
Yeah.
Let's talk a little bit more specifically about the Parkinson's. And you had talked about the progression, those kind of the 7 pillars or whatever. Explain that a little bit of development that you are tapping into with the middle level patients with Parkinson's, because I don't think everybody
So,
knows that. So
yeah.
the mental.
I want to preface what I'm going to say for anybody here who's a teacher and who has worked with someone with a neurodegenerative condition, in particular Parkinson's, But any condition, really, as long as you have some sort of foundational understanding of the pathophysiology of that condition, you can actually apply any of these movements. My anchor movements are the 11 absolute must-do exercise mini sets for Parkinson's disease, but they can be applied across a broad spectrum. That being said, I would like everyone to understand very deeply that disease progression is not linear to disability, right?
Yeah,
So even if a person is progressing, it doesn't mean their disability is getting worse and worse and worse.
correct.
And I want to just give an example quickly of this. We were teaching in Mexico, and the test out of our big courses is we actually invite clients in who have Parkinson's disease, and all the teachers get assigned a client. They've never met them. They have to use what they've learned in this course to create programming for that client on the fly. And so there's more to that, but I want to get back to the story. So we have in Mexico, because we've taught there several times, a client who is always one of our test out subjects. And so she came, and from one year to the next year, I did see a progression in her Parkinson's condition. So she did move from stage one, starting to move into stage two. And we know that because in early stage or stage one, the symptoms are predominantly unilateral. So you'll see them predominantly, maybe let's say it's a tremor, it's primarily on one side of the body. But as you progress through these stages, when you start getting into stage two, it becomes bilateral. So in this case, this client who came to be a demo person for the second year, she had progressed to bilateral. However, in terms of disability, she still had the most beautiful upright posture. Her movement was great. Her color, her animation looked fabulous, and she had a huge smile on her face. So, this is always an indication that, yes, things might be getting a little more difficult, but she's still doing quite well. And again, it's because your progression doesn't mean that your disability is going to become, equal to that.
We saw the same thing. I mean, it was 10 years of a group of persons with Parkinson's doing Pilates twice a week. And you can always go click on the Polestar Parkinson's video in YouTube. But when you hear them talking, things of like, I haven't had to increase my L-DOPA for 5 years, which in a progressive disease, what we would typically would see is that people would have to have more and more L-DOPA or synthetic dopamine that then leads to other types of side effects that you would see,
Yeah.
dyskinesias and other things like that. And so those were kind of things we saw, or talking about how many hours a day they feel alert and awake compared
Yeah.
to what they were before. So even though it is a progressive disease, these are individuals that are noting that 5, 10 years out, they are more alert and more active, even though we know the disease is progressing, that they
Yeah.
are slowing down the disability that is associated with the disease progression. I think that's the
Absolutely.
thing that you're saying, Cecilia, is that
And there's
your
there's other wins
quality of
also.
life is really
Sustaining.
sustaining. Yeah.
Yeah. And there are other things too. I mean, the big rewards are, things like I was able to go on my family vacation with everybody and I didn't hold everybody up. I could go up and down the stairs. I no longer have back pain, which that's another thing that I want to mention about the P4P method. One really crucial piece, which I didn't mention this earlier, but I also studied with Dr. Suzanne Martin, who's just fabulous with scoliosis and spinal asymmetry. And she really opened my eyes into seeing the body in a different
Another
way.
Northern Californian.
Yeah. And the thing that's so important about that is if you decide you are going to work with the Parkinson's population, you must have some sort of background knowledge, take a workshop, buy a book, look up exercise, but you have to have some sort of knowledge of scoliosis and spinal asymmetry, because in a condition like Parkinson's disease, which is very much so a forward flexion condition, if you do not have an obvious scoliosis or spinal asymmetry at the time of diagnosis, you will decline towards having one. And if you do have one, it's going to exacerbate the condition. So most of the clients that I start with, especially those who are in later stage and who don't really have such a background in any kind of physical activity, or maybe they're much older, they all start with back pain and back issues. And one thing we teach at Pilates for Parkinson's is that if you've got an orthopedic condition, which is a scoliosis and a spinal asymmetry, and you have a neurodegenerative condition, Parkinson's, which one are you going to program for first? You have to program first for the scoliosis and the spinal asymmetry, because if your client's in pain, you're not going to get anything good out of them. Everything's going to be subpar. So recognizing that and being able to work that in the beginning to start getting them out of pain, comfortable with their movement, comfortable with doing a little more, that's going to pay you back in the long run. And it's going to buy in a huge amount of trust on their side because you've now helped them be out of pain.
And just to be clear too, it might not be, especially if it is a idiopathic scoliosis, you're not going to necessarily change the scoliosis, but what you're
Right.
saying
You're
is that you're
managing.
going to manage it and you're going to relieve pain. And if you relieve pain, you're
Absolutely.
going to increase activity through those
Absolutely.
successful movement experiences.
Yeah.
Absolutely, yeah.
Yeah.
That's my neck of the woods as soon as we get into chronic pain and anything with spine.
Okay.
But let's move on and what were some things that you did to prepare yourself to work in this population? Like, who did you study with? What did you study? What was the school of hard knocks as well, just going through and working with different clients? What was
Yeah.
your path? How did you get in?
Well, it's one thing that was really kind of odd. I get asked a lot, how did you get started? And I did talk about my first
Yeah,
client, but that wasn't real. That's how I like fell
interesting.
into it. But why did it keep going? And the irony is that I always say that I feel like I was chosen for this work because literally everywhere I went, every studio I've worked at, every private I've taught, when I get to a new place or I'm starting something new, someone finds me and they always say, I have Parkinson's. And that just started to become such a huge trend for me that I started researching more and more and more. And so a lot of it was just self-study. What really formed or forged the launch pad was when I studied with Lolita and we had to do private projects, and I picked Parkinson's. And so that was a whole launch pad there for formulating a method or starting to put things together. And then once I had that, I started doing more research into fascial, the whole British Fascia Symposium with Jan Trewartha and following the Steckos and following Schleip and, all those amazing Gil Headley, just all those amazing fascial scientists. Then there was the piece of neuroscience research. So really understanding things like
Oh,
BDNF, brain-derived neurotrophic factor, insulin growth factor, glial line cell factor, like what are all these things and what's happening? Studying scoliosis and spinal asymmetry, doing a lot with LDOAs to understand separation of the vertebrae and how to find space in different joints and vertebrae. So, it's been a lot of self-study and then going to all the major Parkinson's study pages. Parkinson's Foundation had something, American Parkinson's Disease Association offered. So whatever was offered, I just started taking it all and just started evolving it.
yeah. I think this is really important. One of the things we talk about in just amongst ourselves in Polestar is that you don't need a license to have knowledge. And then the key is, how do you practice within your scope? So it's like, you're not making the diagnosis, you're not doing that, but you understand what the diagnosis means or what the progression means. You understand
Absolutely.
how the medication is like a Band-Aid a lot of times in replacing dopamine, but it is not a cure for what's going on in the nervous system. And sometimes it's quite the opposite, that the more, just like you would see with diabetes, the way you would see it with other hormone replacement or neuropeptide, neurotransmitter replacement, what we end up doing is shutting down the system even more. So in Parkinson's in particular, the longer they can go without increasing their synthetic dopamine, the better, the slower the progress of the disease. Because what happens is if you're always replacing, and you need L-dopa, you need it for them to function. So my point is if your movement therapies can delay the need for increase of the synthetic dopamine because their substantia nigra is working some and being challenged, and you're creating that through your movement experiences, then you are increasing the quality of their life for longer. And we've seen this over and over and over again. I have a podcast coming out probably in the next month with a Dr. Lerman, neurologist in Miami, specifically about Parkinson's disease, and looking at this idea of finding balance where the neurologists are wanting their clients to be involved in these type of movement programs because they know that it's going to, one, improve the quality of their life, but two, the progression of having to do more advanced interventions pharmacologically or surgically are reduced. And that's
Well,
what he's saying.
can I just say exercise is actually, in a way, I mean, you have to think of it like this. Exercise is kind of like a pharmacological approach, because through exercise, you're changing the chemistry of the brain, the
That's an internal
BDNF, the
pharmacy.
idea.
That's an
Yeah,
internal pharmacy. And
internal
absolutely,
pharmacy, right. And it's highly individualized. So even though, yes, that's correct, they could potentially have a decrease in the types of medicines they're taking and the quantity or the occurrence of how many times they're taking it. It's so individualized, and we really, really have to take that into account, because every single person, there's a famous expression in the Parkinson's community, says if you've met one person with Parkinson's
you've met
disease,
one person.
you've met one person. And I've been doing this 25 years, and I can honestly say I cannot apply the same program to every single person. It has to be customized for what
And
they're
that's
dealing
and
with.
that's true with everything, Cecilia. That's not, we teach it's always about the individual, and there's no assumptions that you should make on any of these things.
Yeah.
And the research does show, however, that the movement, like inside of that individual's pharmacological future, that good movement therapy is going to provide a better outcome than if they don't.
Yeah.
I just
Yeah.
lost a dear friend of mine to Parkinson's disease last year,
I'm
passed
sorry.
away, and had a very aggressive, very progressive form of degeneration over a period of like 8 years, and he died at 68 years old. No matter what pharmacological, no matter what exercise, I mean, he was an exercise buff, brain implant, everything, and it just, his path was very aggressive. And it wasn't considered a special form. It just was a very aggressive version of traditional Parkinson's disease that
Well,
took his life.
yeah, that could very well be, but thank you for bringing that up. There
There
are
are other,
actually indeed different Parkinsonisms, and there's Parkinson's plus disorders. So, with P4P, we really have to take that into consideration, because again, the training format will change if you're working with someone who has Parkinson's disease versus someone who has a Parkinson's plus disorder, like progressive supranuclear palsy, for example.
yeah, we have a
So
question on the board for that.
sure.
Way. Sandra, a friend of ours in Miami, said, I have a few patients that have PSP, progressive supranuclear palsy, which is often misdiagnosed as Parkinson's, which we've
Yeah,
seen. And any suggestions would be greatly appreciated. So she has
absolutely.
other Parkinson's patients as well.
So I will just say, as a quick thing, if you're going to if you're going to work with your clients who have PSP, the first thing is you will never take your eyes off of them. You will always have your eyes on them. So in PSP, one of the consistent things that can happen is that they will fall backward without any warning. They don't even know they're falling backward. 1 minute they're standing, the next minute they're on the floor. So when I train my clients who have PSP, I always have them up against a wall, up against a counter where their back is to the counter. up against something where if they're going to fall back, they're going to fall back and land softly, a couch, a bed, something like that. So that would be one suggestion that I would have for PSP.
Yeah. And just continue down that line, Cecilia. I mean, I think the primary cost of care and the danger of Parkinson's-like diseases and Parkinson's is falls, that the risk of falls is great. And that's the other big benefit, that, the more that we have them moving, it does seem to decrease the risk of falls,
Yeah.
or at least increase the awareness of loss of balance. The festinating gait. I saw somebody the other day fall down in a Starbucks, um, and he caught himself on a countertop, but I mean, he was going down and, bashed his elbow and was bleeding pretty
Oh,
bad from his elbow. But, you fall another direction. And that was something that we learned in this population, as well for those 10 years, was that we never made the assumption that they were just going to pop up off the machine and transfer to another piece of equipment or change or to address
mm-mm.
that. So
No, no, no.
there was always a
Also,
one-on-one attention, to
yeah.
a lot of these clients.
So a couple more things I want to add. Yes, the falls is a very key factor. By the time you get to mid stage, that's where ambulatory devices are introduced usually, unless you've got a primary motor symptom of postural instability and gait disorder, in which case the ambulatory devices usually come much earlier in your diagnosis. But the difference between ambulation and gait and falls and someone who has PSP is very different, because PSP, their tendency is to fall
Backward.
backward,
Yeah.
not forward, with no warning. And someone who has Parkinson's and is experiencing difficulties with their gait, there's different things. They may crumple down. They may get what I call a dizzy downer, where their orthostatic hypertension, which could be the result of some of their medications, is making them so dizzy that they just go down, right? So there's different ways that, as a Pilates for Parkinson's teacher, you will understand how to quickly identify what can happen and be aware of some of the side effects of the typical medications that are prescribed for PD
How often would
clients.
you have somebody coming in that is misdiagnosed with PSP?
Well, I haven't had, it's not so much being misdiagnosed with PSP, but not diagnosed with
Well, that's what I
PSP.
mean. They come in
Yeah.
thinking they're Parkinson's, but they actually have PSP.
That hasn't happened to me personally as much, but I did have a client who was misdiagnosed with the Parkinson's plus disorder of corticobasal degeneration. And in that case, dopamine is not as effective. In fact, it makes their Parkinson's worse. And so, unfortunately, there's a medicine science is such a fine chemistry, that it's hard to get the right dosages and times of the medicine. So I know that the neurologists are doing the best they can. However, when you're misdiagnosed and you're given the wrong medicine for a period of time, you're just on this horrific roller coaster ride.
Um,
So that would be something that I have seen myself, a misdiagnosis like
Yeah,
that.
that's something I really like about this one physician that I refer a lot to, Dr. Lerman down in Miami, was because he does such a good job of titrating and looking at, what the reactions and documenting it. And the timing is everything. I would say the other thing too is like the timing that they come in for their Pilates session in their day, like being sensitive to
Absolutely.
what is
Yeah.
their shutdown time of the day. You bring somebody in and
Yeah.
their, medication's wearing off, and it's like
Yeah.
not a good experience, to
So this is exactly like with our training. One of the things we do in our intake is we get the list of medications and the dosage times. So we know when the on state is, because that's when you have an opportunity to do the most good for your client and to download new information if you need to, if they're in early stage, working with a functional motor learning system, versus if they're in an off stage or getting close to the medication timeout, you're not going to get as good quality work
yeah,
out of
yeah,
them. Yeah. So timing matters. Absolutely.
very good. There's a question here before we go into the final part of the webinar today. And by the way, Cecilia, the information's been fantastic, so I really
Thank you.
appreciate
Yeah. There's so much. There's
it.
so much that we can
And
do.
we're just barely scratching the surface, but I I can tell you from experience that there's really good information coming out that is very well supported with research and
Yes.
good documentation on that
And P4P is backed. Everything I teach in my course has
evidence.
scientific references right behind it because, you know, we have to be at the cutting edge if we want to get cutting edge results.
Yeah, exactly. There's a question here, and I'll address it pretty quickly, but it's just if there's any similarity between how you would work with Parkinson's versus multiple sclerosis. And again, I'll just say that you go back to understanding the diagnosis and you understand what the physiology is of that diagnosis, where you might see multiple sclerosis can manifest in a million different ways because what it is an autoimmune disease that attacks the conduction system of the nerve. So you lose conduction of certain nerves in the central nervous system. And so it could manifest in speech problems, movement problems, spasticity. It could manifest anyway. And that, again, goes back to what Cecilia talked about earlier. Is like every patient you take, on as an individual and you find out what they're dealing with. Some have one episode in their whole life and some have episodes every 3 months. It's just a very, very hard disease to compare. Where Parkinson's disease, again, even though it's a neurological disease, is very different from MS. And so
Well, I'll just throw in one more thing to maybe add to that. They are both neurodegenerative conditions, and in MS, you're looking at the deterioration of the myelin sheath. So that's like the little coating of the nerve, right? So
that's a nerve conduction.
it's very different. Yeah. So in a case of would I apply the same 11 absolute must do exercises? Yes, I would. But to Brent's point about having an understanding of the pathophysiology of the condition, in multiple sclerosis, just as a simple thing to note, you can't overheat the person.
Yeah.
So you have to work at a level where they're being challenged, but they're not overdoing it. Like their heart rate's not going up. They cannot get sweaty, so that's something very
Which is
different than
that's the
Parkinson.
beauty, but that's the beauty of Pilates. We'll save MS for another day because I
Yeah.
got
And
more
that's
questions
not
here.
my ballpark. There's
And
other fabulous
having
people
worked
for
with a
that.
lot of multiple sclerosis, it's just very different. And the overheating will set them back for a couple days. It's not the end of the world, but they feel miserable for
They
like
feel miserable. Yeah. And
and
there's no
if they
need
have
to,
that, then they don't want to come back. So it's like
yeah.
there's just some little tricks of how we create the positive and put on top of everything that Cecilia and I have said today is you're creating positive movement experiences for these individuals. And when we create these positive movement experiences, the nervous system, the fascial system, the integumentary, everything goes through a more positive shift. When you create a negative experience, it goes the other direction. And so it's like the more that we can create positive movement experiences, the better. There's another question here from Heather, and talking about the use of cannabis for neurological conditions in Australia has become pretty popular. And I want to know if you had any, understanding or awareness of that in the literature. Any thoughts on that?
Absolutely. Yeah. Yeah. So just a couple things. The hallmark motor symptoms of Parkinson's are tremor, rigidity, akinesia, which is a loss of movement, and postural instability and gait disorder. So that spells trap, right? But I always include an extra P on there, which is pain, because even though it's not classified as a hallmark symptom, it is indeed present in probably 99% of people who experience Parkinson's disease. So I have multiple clients who use cannabis gummies, or I had one client who just smoked, his cannabis whenever he wanted. But most of
A
it
lot of it
is
up in Eugene and up in Oregon.
I I don't know, but anyways,
It's the capital.
but most of it is for pain, to give them an edge off of pain. And my feeling is if that's what's going to help you, go for it, because you've got bigger fires to put out than the fact that you're using half a cannabis gummy or a whole one or whatever.
Yeah.
So yeah, I think
And
that's
as
really
it
important to
pertains
look
to
into.
pain medication, I'm a big fan of going that direction before you start going with other types of pain.
Yes, absolutely. Because generally, people with Parkinson's disease are not just on one treatment. they're on five or more medications. And each one of those medications has a little list of side effects. And so, you have to take all of that into consideration when you're creating your programming, because you don't know, is the person throwing up because of something you did, or is the person having a fainting spell because of something you did? You want to keep them safe, and you want to keep them progressing, and you want your programming to be as effective as possible.
Yeah. One more question here from Carol, talking about a client that just was referred to her, had a lumbar fusion right before being diagnosed with Parkinson. So again, that combination. She says that he's, hyper focused on the spinal fusion. And Cecilia already mentioned that and I agree 100%. You address the pain and the
Orthopedic situation.
orthopedic situation
Yeah.
prior, because you're not going to get the participation that you would want to get for the neurological benefits. You just get inhibition out of it. The question, though, looks like it's more about whether doing duos or one-to-one in that particular situation. So I don't know. Do you always work one-on-one, or do you work in small groups? What do you do, Cecilia? You do groups.
The first thing I do is, if the person has Parkinson's disease, they have to be seen alone first, because I need to understand what's going on. And I teach my teachers to do that too. Once you have that going and you have an understanding of who the client is and what their, what the possibilities are, then if you want to suggest a small group, I wouldn't do more than 3. I personally don't like a group environment for a person with Parkinson's disease, not even early stage in my bigger group classes, because in early stage Parkinson's, you have a window of opportunity to jump ahead, to jump in front of the 8 ball, right, so to speak. And so we call it the big push in our P4P stage 1. And P4P stage 1 is everything goes. It's your chance to download and get as much neuroplasticity going as possible. So if you're putting them in a group environment, it's fine. Maybe it's great for a social aspect, but you really can accomplish so much more in a private environment with them. Yeah. And then augment that. If they want to do, in addition, a group thing, that's fine. But I think it's really important that they're seen privately.
That's what I was going to bring up is there is, more and more discussion now about the social effect, like with the Fear of Falls test or study that was done that was so successful, these small groups of 4 to 6 people. You're not quite sure if it was the Pilates, if it was the group setting, if it was, we saw the same thing in our group. What we did is we had 10 clients coming in for a circuit, and we had everybody volunteering that hour twice a week that wanted to be part of the program. So everybody had a one-on-one, one-on-2 max relationship inside the circuit on the equipment, mainly for safety. But they did have the social where, they'd break out sometimes with their kazoos for a birthday party, or singing, or wanting to stand up and dance and do some movement with the music, or those kind of things. But I agree with you that, when you're by yourself, especially if you're learning how to work in these populations, that you stay one-to-one.
So I also want to say, Brent, that the social aspect is important. Most of the Pilates teachers, if you see clients in studio, it's because they're in early stage, because by mid stage, anxiety is ramped up so high that it's hard for them to even get out. So the programming, again, is different. The considerations are different. You have to take into account the anxiety levels, but the socialization aspect is very, very important. And Pilates for Parkinson's, what I am pushing here is that we are the baseline. So it's Pilates for Parkinson's and boxing and yoga and treadmill and whatever else you're doing. But you need this baseline on a daily basis, and you have to have adherence, because that's where all the changes are going to occur. So that's, and one last thing is, look at Pilates for Parkinson's as a movement armamentarium, okay? A movement armamentarium where it's like a toolkit where you have all these specific things, how you can hack into a system where the dopamine's lost and you have irregular movement.
Tell us a little bit. I know we're out of time, but as far as your training program, Cecilia, what does it consist of? So a graduate,
So,
almost everybody that's on here is probably a graduate of a comprehensive training, 450-hour training.
yeah, yeah,
Um,
that's awesome because
what
that really helps.
what's the typical training process, like what you said you did down in Mexico or what you do in
Yeah.
Beijing?
So we're looking at, first off, you need to know the 11 absolute must do exercise mini sets. You have to know what they are. They have to be in your body so you feel them. You have to understand how they relate to the anatomy, to the physiology of a person, and then of a person who has Parkinson's disease. So that's your basic toolkit. Then you have to understand why Pilates comes into the picture, because it's not the Pilates exercises or the mat repertoire necessarily, it's the principles and how we use them. Then you go into everything from the cerebellum, the neuroscience, neurocognitive approaches, neurovisual exercises. You go into augmented trainings like the 7 primal movements, the the neuro developmental sequence, the Pakwa. You learn the Pakwa, some of the movements that are used. So there's so much. Then you learn how the stages, how we match our stages to the stages of Parkinson's disease. What do our stages consist of? Why are they that way? What are we looking at? There's an NLP section. There's intake formulas. There's creating your specialization. I mean, it's a pretty in-depth program, very comprehensive, and you will be able to work with anybody in any stage by the time you're done with this program.
The time frame and the commitment, what does that look like? What's the
Well, this big course is, you can have 2 options. You can do a live course, which is 20 hours. It's very intensive, but the benefit is that you get to be there for the live programming and work with an actual person. The alternate to that is an 8-week program where you meet once a week. It's 2 hours and 15 minutes, but the advantage is you can incorporate what you've learned in that lesson throughout the week. And the last one is online learning, which will be up on our new website in April.
All right.
Parkinson's Teacher Training Academy.
Well, we will definitely post that on the post-production, so keep your eyes out for
Yeah.
the newsletter
And
coming
please
out.
send me the questions. I'm happy to answer anybody's questions. I want to help as much as I can. It's really important that we support this community.
Yeah, absolutely. We support you. We support the community. Thank you, Cecilia, for all you're doing and for being a leader in this area and taking on. I think the other beautiful thing here to say before we close is, as Pilates teachers, and I don't like anybody to say just a Pilates teacher, as movement teachers, we have the ability to influence a population that is struggling. It does require hard work. It does require extra learning. It does require mentorship and guidance and direction. But I want you to realize the example that Cecilia has set over the last couple decades of diving deep and becoming so familiar with the science and so familiar with the work that her competency level is very high. And if you were to take that same thing and move it into the physical therapy world, we would not have the same quality of movement that you would be seeing with the Pilates teacher that is extremely well trained. So keep that in mind, that as we continue to build the continuum from disease rehabilitation to performance, the importance of the role that each of us play in that continuum, and also knowing what our scope is and knowing that the more knowledge we get, the more understanding, the more experience creates greater trust amongst the whole spectrum of professionals, and allows us to focus on the client more than on our profession. And to me, that's the most important thing, is that we're creating really good experiences for our client. Cecilia, thank you so much. And we'll certainly be sharing all of your information with everybody in the post-production. Everybody, just a quick shout out to remember to live aligned and be kind. And we'll see you next week at another
Thank you.
Pilates Hour. Thank you, Cecilia.
Thank you so much, everyone. Thank you, Brent.
Mhm.
Bye-bye.